Hello, I'm Dr. Christoph Correll, and today I'll be talking about what is the role of the muscarinic receptor system in schizophrenia. Let's first understand the acetylcholine system. There are two different receptor types. There's the nicotinic receptor, which is ion-gated, a channel receptor, and is fast for synaptic transmission. We'll not be talking about that today. But there's also the muscarinic receptor system. That is a G-protein coupled receptor and has second messenger cascades. There are 5 different members of the muscarinic receptor family. And we have the odd-numbered ones, M1, M3, and M5, and those are postsynaptically sitting receptors. And when they are stimulated, there is a stimulatory or go signal. The even-numbered receptors, M2 and M4, on the other hand, are presynaptic receptors. And those are autoreceptors. When autoreceptors are stimulated, it's a stop signal. We also need to understand that the muscarinic receptor can be either stimulated by the orthosteric receptor, which is the pocket where acetylcholine or the endogenous neurotransmitter goes, or it can be modulated by the allosteric pocket, and there we can have positive allosteric modulators. That's important because the orthosteric site is very much shared in the configuration by the 5 muscarinic receptors. So there can be some spillover into other receptors, and it's not as specific to just 1 or 2 of the muscarinic receptors. The allosteric site, on the other hand, is very specific. And when you have a positive allosteric modulator, then acetylcholine binds more tightly and transmission on that receptor is strengthened. Why are we talking about the muscarinic receptor system in the context of schizophrenia and in the future maybe even other psychiatric disorders? Because the M1 and M4 receptor are located in areas of the brain that we believe are very relevant for schizophrenia, but also other types of psychiatric disorders where there is too much dopamine in the presynaptic synapse. What's the storyline or the narrative of the muscarinic receptor modulation? Well, it's actually a system that has been activated very early. In 1959, there was the first study where arecolin, which is a derivative of the betel nut, was tested in 28 patients, and 80% of patients had lucid moments, meaning that they were not psychotic. However, this was not pursued because there was also a lot of procholinergic side effects peripherally, nausea, vomiting, and also orthostasis and syncope. In the 1990s, there was another approach to look at cholinergic activation in the frontal lobe via xanomeline. And xanomeline was tested in patients with dementia who had agitation, psychosis, but also obviously cognitive problems. And in that study program, 6-month study, xanomeline, an M1/M4 agonist, was effective for treating cognitive dysfunction in people with dementia, but also had a very strong effect size, not only for activation and agitation, but also psychosis. However, again, without titration or a peripherally restricted anticholinergic, there were too many side effects to carry this forward. In 2008, there was a very small study with xanomeline in schizophrenia. 10 patients on xanomeline, 10 patients on placebo, and both for cognition and psychosis, xanomeline, the M1/M4 agonist, was superior to placebo. But again, the side effects were such a limiting factor. It took a while until there was the idea to actually isolate the central efficacy of xanomeline by adding a peripherally restricted anticholinergic trospium to xanomeline, creating xanomeline-trospium combination. And that has recently been tested in 3 studies, and they were all positive. There was also safety. And on the 26th of September 2024, the combination of xanomeline-trospium was approved by the FDA as the first member of the muscarinic class, having muscarinic agonism. How does muscarinic agonism work as an antipsychotic? With the M1/M4 stimulation, there is a top-down and bottom-up antipsychotic effect. Let's talk about the bottom up first. The M4 receptor is an autoreceptor, as I mentioned. When it's stimulated, you're decreasing acetylcholine. So you're decreasing the input of acetylcholine from the hindbrain to the midbrain. Acetylcholine and dopamine are friends. When acetylcholine is up, dopamine is high. As we're now stimulating M4, the autoreceptor, we're decreasing acetylcholine in the midbrain, which then decreases acetylcholine-stimulated dopamine in the associative striatum, where we believe psychosis resides. At the same time, there's a cholinergic interneuron in the associative striatum, and when here acetylcholine is reduced by M4 stimulation, we also have a decrease in presynaptic dopamine transmission. That's the bottom-up antipsychotic effect. We also have a top-down effect, where the M1 receptor stimulation stimulates GABA, which is the brake in the system, an interneuron, which then decreases the gas pedal, which is glutamate. And the glutamate input into the ventral tegmental area, again, stimulates dopamine. So by stimulating GABA, reducing glutamate, we're reducing dopamine input presynaptically in the associative striatum. Those are the two antipsychotic mechanisms that decrease presynaptic dopamine, where we believe the problem in schizophrenia lies, whereas our current or previous antipsychotics have always been a postsynaptic blockade answer to a presynaptic problem. Since the M1 receptor also is in the frontal lobe, stimulation there can increase acetylcholine in the frontal lobe, which then can lead to procognitive effects. And this M1 stimulation actually, by stimulating GABA, decreasing glutamate, also restores the EI imbalance, the excitation-inhibition imbalance that we believe underlies schizophrenia, at least in subgroups of patients. Thank you for your attention, and I hope that this was information that is useful to you.